So obviously I do support a belief that we need to see a cultural and philosophical shift to a system that embraces trauma-informed care and support, care and practice across the board. It's going to require sustained commitment and investment in services and programs, and systems will need to integrate awareness and understanding around trauma and traumatic stress in their work and approach people from a trauma-informed perspective. That is, to always consider the possibility of undisclosed or unaddressed childhood trauma at the root of all presentations. Being cognizant to the possibility can make an enormous difference to the way a survivor reacts and copes going forward. So in a trauma-informed system, survivors' conditions and behaviours will be need to be viewed differently, staff respond differently, the day-to-day delivery of services conducted differently. System understands the connections between the past trauma and the current behaviours, develops strategies for responding to the complex trauma. How are we going for time? The new system will be characterised by safety from physical harm and re-traumatisation, an understanding of survivors and their symptoms in the context of their history, of their culture, of their sexual orientation, of their ethnicity, gender and community, collaboration between workers and those seeking help, an emphasis on building on strengths and acquiring skills rather than managing symptoms, a perception that childhood trauma was a defining set of experiences that forms the core of an individual's identity rather than as a discrete event, and a focus on what happened to the person rather than what was wrong with the person. Agencies should routinely consider the possibility of trauma, even when it hasn't been disclosed, focus on creating safety and increasing access to trauma-specific services when supporting people who have disclosed. So these are some feedback from the States, which has already instituted trauma-informed care and practice in some pockets, and basically, very good outcomes. Decrease in psychiatric symptoms, substance abuse, trauma symptoms, hospitalisation, crisis care, an improvement in consumers' daily functioning, cost-effective, better outcomes for staff as well as consumers. So that reference actually has, quite impressive studies. And, when I read that, it's game, set and match, so I'm not actually understanding what the resistance is. Just a little bit about ASCA. ASCA is a small organisation, and we advocate for the needs of the more than 2 million Australian adults who suffered child abuse and neglect, and we're advocating for for their needs to be better met by a trauma-informed approach to care. Call us our 1300 line, listen to their validated. Safety is an absolute priority, as is confidentiality. Disclosure is handled. People ring and are telling people for the very first time, and the way that is handled is absolutely crucial. And when people need referrals, we have developed an ASCA-endorsed database of people who we feel have the minimum qualifications and experience to deal appropriately with trauma. And if anyone here wants to register and fill out a questionnaire for that database, we've got the information on the desk. We also run psychoeducational workshops for survivors to help survivors connect their past trauma with their present experiences and feelings and give them tools and skills for positive change. And we've also developed some training for community workers, health professionals, to develop a trauma-informed workforce that better responds to the complex needs of survivors. Just like to finish with a quote that came from one of our workshop attendees. Please educate counsellors, psychologists, anyone who comes in contact with survivors of child abuse that it can have lifelong effects. We cannot move on until we've dealt with our baggage and it takes a long time and endless patience and support. We don't want to wallow, however we need to deal with and express our pain and anger and go through the stages of grief and loss for our lost childhood. Counsellors need to understand the stages of childhood development and realise the impact of not experiencing these important developmental stages. I don't believe there are any quick fixes. We need to be listened to, have our experiences validated. Counsellors with little experience, despite the best of intentions, can do more harm than good. Inappropriate help kept me in denial and isolation for many years. Thank you.
Presentation and describing so clearly the challenges that survivors experience and what's necessary to support them. It just seems like it's not rocket science, but it seems to be such a difficult thing to get over. So are there any questions for Cathy? Warwick.
Thanks, Cathy, for an excellent exposition. Just reminded me, and I maybe should have mentioned it before, in terms of mainstreaming trauma-informed care, it's really nice to see the sort of subject that you're talking about integrated into mainstream mental health conferences. And I'd just like to mention to people that you, Judy, Maria and others are actually speakers at the World Congress for Psychotherapy on the 24th to 28th of August here in Sydney. The issue of trauma-informed care has actually become a mainstream theme for, a central part of the conference, and one of the days in which this happens actually includes an international panel on the sorts of things that you're actually discussing in terms of service provision that incorporates an appropriate awareness of trauma. So I just thought I'd mention that if anyone actually would like to follow that up further and actually experience these sort of issues as being centrally placed in a mainstream mental health conference, you might like to check the website for that. It's well worth attending.
That's good to hear, Warwick. Didn't know that.
Make a comment while somebody's getting up. Thank you, Jan. In the research I was doing, that I've been undertaking just recently, looking at trauma-informed care implementation in a unit here in New South Wales and one in New Zealand, the comment that you gave about resistance, why the resistance? And I think the thing came through with one of the clinical directors I spoke to and said, basically, we can't go trauma-informed care because we need to be risk-aversive. So I guess it's that understanding of, do we have a collective understanding of what trauma-informed care is within mental health inpatient settings, and why do we have to be risk-aversive to start with?
Well, hopefully is this still on? Hopefully this conference is going to help get us towards some of that place, but I can't see how introducing a trauma-informed approach is going to actually exacerbate risk at all. On the contrary, I know that just seems that there needs to be a lot more education and information to challenge that.
I think so, and I think it's the place that we probably need to go, is that education within mental health around about it.
Yeah, that's right. Yeah. Well, yes, but again, that's also. Corin, come to the microphone.
I was just saying, I think that there's an issue around fear of there being disclosure and then not being able to deal with it, and hopefully there are going to be some people.
Well, that's around education as well, isn't it? That's
who are going to be able to help us a bit further with that.
Yep. Can I just say, Cathy, that I come from Wagga Wagga, and there is a women's health centre in Wagga which is in the process of developing a trauma-informed care service we have funding for adult survivors of child sexual assault as part of our core funding. I would like to suggest that part of the resistance is because you cannot hide behind a professional facade if you're going to do this work. And that even in our process in that centre of working through, we all had to come to understand that we all had to face our own feelings about a whole range of things. And that I think that very often when you're talking about this work and the difficulty to find people with the skills or the willingness to do this work, it is the fear of having to identify and feel our own feelings, which often, I think, in my observation in many mental health services, there's a whole barrier to that engagement happening because that's called professional boundaries. And I think a lot of things are hid behind that concept of what is a professional boundary.
One more. It's me. Is it me? It's two of us. I just wanted to say thanks, Cathy. That was terrific. And I wanted to mention advanced directives, because one of the ways that consumers have developed to stay safer in hospital settings particularly is actually to document what things re-trigger us, what things re-abuse us. It takes a bit of experience being in these places, but it's actually a helpful thing to actually come equipped with our own knowledge about what works and what doesn't work. And for anyone who's interested in that, the state of Maine in the USA have developed a pro forma specifically around advanced directives in relation to trauma, childhood trauma and abuse. So it's worth having a quick look at that, because that gives people an idea of what these documents could look like.
What the issues are. Yeah, thanks, Brenda.
Thank you. Cathy spoke quite a bit about it, and Warwick raised it, and I know Richard did this morning, the whole issue of safety in therapy. I'm just wondering at some point over the 2 days that we're here, if we could throw open that idea that we don't work with safety. We work with people who are often still unsafe. And secondly, we're increasingly working with children coming through the family law system who are institutionally made unsafe, and we need to work with them.
Yeah, no, absolutely. But it's about making them obviously as safe as we can in the process. Yeah.